Questions?
Kelly, we have one back here.
Hey, Kelly. Got a question for you. What can the state government do to eliminate artificial barriers to competition? And the thing that strikes me head on is certificate of need programs. Is that outdated? Is that seeing its better day? Do we need to open up the competition to the marketplace as opposed to having the government regulators determine who gets a certificate of need or not?
I can talk on CNN a little bit because this certainly kind of falls into my space. I'm a surgical specialist, and CON from our aspect, and probably plays a little bit different out in Jimmy's area. I work in Atlanta, and I work in a high-cost system, St. Joe's Hospital System, Emory Hospital System. We've got Northside Hospital System nearby. Those are high-cost hospital systems. If I decided to do what they do in Oklahoma at the Oklahoma Surgical Center, it's a direct pay, multi-specialty surgical center where they post their prices, they don't take insurance, they compete in the marketplace for the delivery of health care, and they do it very cheaply. If I wanted to set up a multi-specialty surgical center in my area, I can't do it because of this, because of CON laws. But if we really wanted to find a way to bring down the cost of a knee replacement that costs $30,000 in a hospital and get it done in the outpatient setting for $15,000, we could do it. If we wanted to knock down my $10,000 ureteroscopy to take care of a kidney stone in the hospital, but allow me to do it for $2,000 in my outpatient surgical center, we could do it. If I want to do the same thing with an appendectomy, a cholecystectomy, a single level spinal fusion, all of these things have added a tremendous amount of cost because we are done in the hospital, because we can't develop some of the economy of scale to be able to have multiple specialties do it together in an outpatient surgical center. And so Oklahoma, they actually had a contract that they signed with the local board in Oklahoma, the local school board, and they had 10 surgeries in the past month since they signed this contract that were done in the Oklahoma Surgical Center. It cost them $58,000. If those surgeries were done at the prior rates 1 month prior to that, it would have been $215,000. Saved $160,000 just since the initiation of this new contract. That's leveraging down the cost of healthcare. Makes things much more affordable. And when somebody's having to pay, in today's environment, greater cost sharing, having to pay $4,000 deductibles with $6,350 maximum out-of-pocket expenditures, and I can say I can do your stone in my outpatient surgical center for $2,000, but I'm sorry I can't because the CON laws don't allow me to make that happen at a cheaper rate. I'm sorry, you're going to pay $6,350. That's not access to low-cost healthcare. So in my mind, it needs to go away. If we really want to compete in the marketplace, it needs to happen. Now, that's going to impact Jimmy. It's going to impact hospitals. But we need to have that conversation then, not cross-subsidize, not create cloudy pictures about the cost of what that surgery is, but separate into low-cost care and then allow us to start figuring out really where the cost drivers are in these hospital-based systems.
I would piggyback on that and say the capitalism and competition are going to exist whether you allow it or not. So, in a state that says, no, we're going to maintain our certificate of need because we want to protect the hospitals that are there, it will just drive patients to other states. For a $200,000 savings in surgery, yeah, I'll go to Oklahoma. I mean, that's the rub. For a cost savings that big, people are going to look for those opportunities. And for your employers, they're just going to move to states where, we had that with Boeing just left Wichita because the union contracts and health insurance, they went to a state where they could get it cheaper. So it's going to happen. You might as well, I think, embrace good business and remove those restrictions so it can happen in your own state.
And medical tourism is happening. I did an interview on medical tourism. People are either flying in the States or they're going international, whether it's India, to get their knees done in India. Why don't we make it happen here? It'd be a great thing for us to be able to do, wouldn't it?
Jimmy, you want to chime in?
I do have a little different view on this.
Let the record show we've addressed the two most controversial issues in Georgia.
That's right. So the way I look at CON is the bad news is Georgia is a CON state. The good news is Georgia's a CON state. And here's why. I talked earlier about the tremendous fixed cost in a hospital. If there aren't patients, then we have excess supply, and we still have to carry that cost. The cost of one more MRI is maybe $2. The cost for us to see one more patient in the ER, I did a rough back-of-the-envelope analysis not long ago, and it startled me. The cost to see one more patient in our ER is $9. And it's calculated by the variable cost divided by the number of patients. So if we take this demand away, then we're going to have higher fixed costs, and we're going to have to charge more per patient if we keep the hospital in business. So what we have to be prepared to do is, one, and there's another point, is the hospitals are going to be left seeing all the uninsured patients. And sooner or later, and this is where we are now, there are no more insured patients to shift that cost to. So over time, we've shifted costs to the insured patients. Their premiums have gone up. Some of them have dropped off the insured roles and become uninsured, and we create a vicious cycle. And that's putting hospitals out of business and raising the cost to those that are still insured. We've got to break that cycle first. Then we've got to figure out how do we change the distribution system and spread this fixed cost out throughout the system instead of having it replicated in every single access point. Then we can truly bring down the cost, and then we'll have a free market that'll work. Right now, hospitals are not functioning in a free marketplace, unfortunately, because I wish they were.
If we had this plan we're talking about, where we've turned your uninsured and your Medicaid recipients into privately insured individuals, or you're getting a lump sum payment, that puts you on a much more level playing field, right?
Absolutely does, yeah.
Yes. Another question.
Hi, Kelly. This is Linda Clary Umberger. I'm back in the back corner over here. Thank you all so much for the differences in your each own way you're trying to make in medicine and improving health care. Here is my question. Unfortunately, this year, my husband was diagnosed with a form of lymphoma. And because of a reaction to one of the chemos, he now has pleural effusion. And how do we fix a situation where an insurance company, we do have insurance, sits on a request for over 3 weeks, and each time I call the insurance company, the cost of the vacuumized bottles ranges, depending on who I speak to, from $134 to $200 each. Then, when I finally throw my hands up in the air and say, what is it going to cost if I pay for this completely out of pocket, it doesn't go to our deductible, and I'm told, oh, that's real simple. That's only $59. When do you want us to ship them to you? And how do we solve that problem? Because to me, that's a huge part of this obstacle we're trying to get over.
I'll take that. Einstein said if you judge a fish by his ability to climb a tree, he'll forever think he's unable. And we're using insurance for the wrong thing. If it's $59, why are we insuring it at all anyways? So, I mean, that's the first part. To make insurance more affordable, use it less often. If the situation was reversed and I tried to sell you car insurance that was structured like health insurance, you would see that for the fallacy that it is instantly. You can only get 2 tanks of gas a week and only from these gas stations, and I have to pre-approve a trip out of town. It wouldn't make sense. So we're using insurance for the wrong thing. Even though it's a serious condition, we shouldn't be doing that. You should be able to go to your doctor, whoever your provider is, and be saying they should be shopping that for you and getting you the wholesale rate or a good price so that it's affordable enough to not go through insurance. But the more people you involve. So, the short answer, and I think this is maybe an unpopular, unexpected answer, is make insurance profitable. Profitable businesses work really well. And insurance is so, bogged down with red tape and restriction that they don't know if they're coming or going either. And if we could, use them less, they would be a more efficient business. Things would happen easier.
Hi, my name is Baha Zidan. I'm the CEO of Azalea Health. We're a software company in Atlanta here. And actually, we're in rural Georgia. We started in Valdosta, Georgia. One of the things that I see in the healthcare, that's the core, which is pricing, but the phantom pricing is a big issue. We have providers, they go, my fee schedule is 3 times Medicare. The other person, 2.5 times Medicare. Is our health system ready for price transparency, where if I'm a consumer, I can go online and see what's your price, and what's your price. And would you support legislative way of making that happen?
So
Thank
price transparency is great. I do some work with the Institute of Healthcare Consumerism. We had a conference in May, and there was a tremendous amount of people that were there trying to push the idea of price transparency. Sure, shine a light on a really expensive product. Right. You got a colonoscopy that's going to be $3,000 versus another one that's going to be $3,200 versus one that's going to be $3,500. Colonoscopy should only cost $500. So I think price transparency is wonderful. We do it through contracted rates, but it's an expensive system that we're shining a light on. So if we really want to shine a light on an inexpensive product, we've got to find a way to get rid of all the unnecessary administrative excess cost in the system, the poor model, because that's the disease. And we're trying to talk about remodeling the system and its economic delivery. We do that, then maybe we can actually bring price transparency. And when I actually get to say, well, I charge $80 for you to come and see me, without having to deal with an insurance company, and my urology colleagues downstairs decide to charge $60, you can put that price out there. And then I'll actually have to compete to say, I either bring a better product forward, or people are going to go downstairs, or I better drop my price. That's really price transparency with competition in the marketplace. But right now, we're still working within a very high cost, unnecessarily expensive system.
I think the other problem with the question is that it implies that doctors know what their price is. And I think most of the time they don't. So it'd be awesome if they knew and could make it transparent. But the other half is the market ready for it? The market's never ready for change, hence disruptive innovation. But that doesn't mean you stop it from happening.
I happen to be on the board of one of our 4 medical schools, and our docs, some of them are running scared. They're about their second year of practice. But running through the arithmetic, Dr. Umbehr, on your numbers, that's generating about half what some of my friends who are in GP, general practitioners, are generating, it sounds like. So are you happy with that?
Generating and keeping, I think, are two different questions.
Yeah.
So great article, March 16th, 2012 in the Wall Street Journal outlines the cost of running a 3-doctor practice in Denver. And long story short, $2.2 million operation, $29,000 in profit, only after a $40,000 grant from an insurance company and 22 staff.
Yeah.
Juxtapose that against our practice, 3 physicians, 1.5 staff, and each physician bringing in between $200,000 and $240,000.
Yeah. Mr. Childre.
So the rough math is $50 per patient per month times 600 patients. That's $360,000 a year.
Right.
But our overhead, we tell most docs $120 for a single practice. Economy of scale works to our favor. It's closer to 90.
Yeah.
So most of our doctors are bringing between 2 and 240.
Mr. Childre, the trends you've got in the rural hospital is alarming. I'm sure you're aware that what the statistics you just quoted are, if it keeps going that same way, you're going to be squeezed so hard it's going to be tough.
We have an unsustainable business model in rural hospitals now.
And we've got, 46 counties that don't even have a doctor here in our state, I think. So
And the answer is not to continue to prop up the system, to protect it with CON, or to subsidize it. We've got to structure the industry where it functions more like a free market so that we can actually achieve a free market. I support price transparency and cost transparency and quality transparency. I also support trying to find a method to have every user paying for their services. We do that through insurance in this country. For example, an uninsured motorist puts every other motorist on the highway at risk if they're uninsured, if they cause an adverse event. An uninsured patient puts every other patient at financial risk because somebody's got to pay for it if the hospital is going to open the next day or stay open until the next day. So there we have the basic problem. We've got to figure out how to do that.
What's interesting with insurance is required to drive, but yet 15% of the people drive without insurance, which is about the same as our uninsured rate. And so we're looking for a system rather than a mandate. Can we go ahead and just say, hey, we're either going to give you the money to purchase the insurance, or it's going to go to the safety net system instead of this convoluted system. Mandate's so hard to enforce.
It is
the problem. Question over here.
Yes, my question's directed primarily at Josh. I am astounded in a very pleasant way to hear your price structure. And my wife and I have a fairly large family. We have 8 children, and listening to that price structure based on my current insurance plan, it would save me roughly 60 to 70% a year off my health insurance cost. And not only that, I really like to me, one of the greatest advantages of your model is you have a built-in incentive to keep my family happy so that we use your services less. You're getting a flat fee regardless. So your margins are higher the healthier you keep us. So it's a win-win. Right now, we kind of live out in the country, and we have to drive 45 minutes one way to get to the primary facility, which is where we have to get our services through. And so I guess what are the primary barriers that, I mean, because I know I would jump at the opportunity to sign up for services with you in a heartbeat. What are the primary barriers to your type of model spreading rapidly?
Well, I'm glad that it works out for your family, and that was exactly the goal, is to make this very affordable. I started watching, quote, concierge medicine in 2000 and watched it change over a decade, and it was always aimed at the 1%. And Lord knows there's nothing wrong with the 1%. I want to be one of them someday. But you can't build a business like that. And so the goal was to make a model that was applicable to the masses. And I don't even think we're at the bottom of the barrel in terms of cost. We see $600. Maybe another doctor does an average of $30 per patient for $800 or $900, just depending on their town. I came from a small town of 900. There was one doc anyways, and everybody might as well pay into that system. But it's funny, a barrier to care in this stance might be gas money. Drive 45 miles each way, or time, access, hours, work. So I find it beautifully ironic that our model actually works best for low SES patients, because when you can call, text, email your doctor, you don't have to leave work. You don't have to spend a vacation day. You don't have to be a low producer at your job in a down economy to get access to the care that you need. So if you come home and find out at 6 or 7 p.m. that Johnny has a rash, email me a picture. You have unlimited access to me. So not to say I don't want you to come in the office, but we're going to utilize those resources so much more efficiently because you have that. So how do we spread the model? Is that the question? Yeah. Physicians. Yeah.
Political and regulatory.
Sure.
I mean, you would think, thank you, you would think that this model would be spreading as quickly as, Starbucks are going up on street corners. I mean, it's just the personalized care, the drastic cost reductions. It just seems like a wonderful product. So, what's going to keep it from spreading, to use that analogy, like a Starbucks?
Yeah, I think it is, and I think it will spread like a Starbucks, because patients are going to demand it. And there's is it from the innovator's dilemma? Or there's a reference to where when a new technology decreases the cost of an old technology by 90%, it must be adopted. You can't forego that much of a savings. So what we're seeing, I may be one of the few of physicians who thanks Obama, because he's selling the hell out of our business model. And I would argue that it is growing at a record pace, because 4 years ago when I started, again, only 1% of doctors said they would consider a model like this, and now 15%. So I probably talk to a dozen doctors a week who are looking to transition to this model because their patients have demanded it, or they've seen our blog posts or podcasts or newscasts or whatever. And so we have had a huge swing in that. I think there will be a paradigm shift where we say 80% of family doctors will be in this model in the next 3 to 5 years. And I've been saying that for a year now. So, but when you can make more money, seeing fewer patients, providing better care more often, why not? I think the only thing that slowed us down really to this point is that most doctors still hear it as concierge medicine and assume it's for the rich, whereas the new buzzword of direct primary care is helping to change that idea that, no, this is affordable care for the masses. This is better care than you're getting at your regular doctor's office, because I can, if CVS wants to put a clinic in their pharmacy, then I'll put a pharmacy in my clinic, and I can beat the price. A penny or two a pill I could give it away and outcompete everybody else. So that will drive the rest of the system to innovate too, continually pinching that cost curve. So the consumer will drive this. The only thing politically is some doctors worry, and there's been very limited confusion. I wish this fear would die, and we're working very hard to crunch it, is that this is somehow an insurance product. Because it's a monthly membership. And there's really no logical argument to say it is insurance. If you go to the definition of insurance, it's a paid benefit, defined benefit for a defined loss based on your premiums. We're not providing anybody with a benefit like that, cash benefit back. You get strep throat, I'm not offering to pay you $20. This is a service, like a gym. You know, this is Netflix to Blockbuster. It's just a better model.
What's interesting, Josh, is that this is allowed under the Affordable Care Act
Yeah, it is.
because
Section
there's actually a
1301.
policy sold on the exchange in Washington State with a direct primary care model and a wraparound insurance coverage for around $2,000. So it's being done. It's allowable under the current regulations. So I think that's pretty exciting. Got time for one last comment from Jimmy, and then we've got to get
My
out.
last comment is going to be a question to Josh, and I mean this with all sincerity and due respect.
That means something good is coming.
So you have about 600 patients a year, right?
600 members.
Per
Yeah,
physician.
per physician.
And it's a flat fee, everybody's paying the same fee.
It's $10 for kids, $50, $75, or $100 for adults through the age ranges. Our
Okay.
corporate price is $50 for all adults.
Okay,
So our average revenue right now is like $49 per member per month, averaged out.
okay, so what would you do if 90 of those patients quit paying?
Quit. Go
Just
back to
didn't
hauling
pay you.
trash.
So if 90 of your 600, or 60, or 75, no longer paid, I guess you'd have two options, to either continue seeing them or not seeing them.
Right.
Okay,
I'd have an unsustainable business model.
all right, that's exactly what's happened to hospitals. You'd either have to raise the price of the others or go out of business.
Right.
Okay.
Thank you so much to our panelists. I think they've done a great job. And hopefully, we certainly understand the problem, and hopefully we've thrown out some ideas, because the whole purpose of this conference is to try to solve the problems. And I would love it to see if Georgia could be a leader in that. So a round of applause for our panelists.